Order. Today is March 1st, and for the record, it's 1:08 p.m. We have two bills today. The first bill is Senator Rosen, Senate File 1160. Senator Rosen, would you please come forward? Welcome to the committee, Senator Rosen. Senator Utke, would you move Senate File 1160?
Thank you, Mr. Chair. Yes, I move Senate File 1160.
Thank you, Senator Utke. Senator Rosen, whenever you're ready.
Thank you, Mr. Chair. Very good to be in front of your committee. Senate File 1160, I'm working off the first engrossment, Mr. Chair and members, is the Telehealth Bill, which the general definition is the use of electronic technology to provide health care and services to a patient when the provider is in a different location. The original Telehealth Act was passed in 2015. And Mr. Chair and members, we passed this bill, I passed this bill in 2015, and I remember visiting the Fairmont Mayo Health System Hospital, and we passed it for stroke victims, basically, originally. And I was in this room with the camera in the corner, which was probably halfway the distance between you and me, Mr. Chair. And the nurse in Mayo at Rochester could tell exactly what my watch was, even down to the second hand. So it's been very instrumental for stroke victims and for our rural communities, because it's, of course, very, very hard to get health care and physicians out there of all kinds. So it was a model delivery for many years, but because of COVID-19, there has been an increased use of telehealth from less than 2% of visits in 2019 to nearly 30% of visits in June of 2020. And I don't know, Mr. Chair, members, if you have used telehealth. I have actually used it a couple times and it works. And the question is, well, is it here to replace in-person visits with your provider? And I say absolutely not. It is, however, a very important option for the patient and a critical tool in delivering health care. Telehealth is here to stay, and the conversation needs to continue on how we deliver that. So Senate File 1160 is a cleaner, updated version of current law. And because there is a change in term from telemedicine, which we used to call it, to telehealth, many sections had to be rewritten, I should say. There's also a number of critical changes that codify the changes made through the governor's executive order dealing with COVID-19. Number one, it redefines originating site to allow services to be provided wherever the patient is located, including the patient's home. The old law required the patient to go to a hospital or clinic to receive telehealth services. Also, the bill removes an arbitrary limit of 3 telehealth visits per enrollee per week that exists for MA enrollees. It includes telephone-only services in the definition of telehealth if those services are a part of a scheduled, and I should reiterate, scheduled patient appointment, and the standard of care for the service can be met through audio-only communication. So really 2 important things here is scheduled appointment and the standard of care. Physicians are held to the same standard of care with audio only as in an in-person visit. Allowing audio communication is current law, but it wasn't really used until COVID-19. The bill also includes coverage for remote telemonitoring services for patients with conditions where it is medically appropriate. Mr. Chair and members, no-shows for people not showing up for their appointments has dramatically decreased. And you will see that and hear that in the testifying today. And it's been very effective in the area of mental health and substance use disorder services. So line 3.22 of the first engrossment says, nothing in this bill requires patients or providers to use telehealth. The provider has the right and the responsibility to determine if telehealth is appropriate, and the patient has the right to choose not to receive care through telehealth. And 2 items where you will hear concerns from the testimony today, Mr. Chair, is from the payers and the business community. Is basically a prohibition on telehealth only networks and a requirement for payment parity for telehealth. Payment parity has always been in current law. for private coverage. This is not new. Line 3.1 of the bill prohibits the creation of separate telehealth-only network that doesn't include a person's providers. Telehealth needs to be used to supplement in-person care and not replace it. And at best, 20 to 30% of care is provided via telehealth. It cannot provide care for all service and to allow insurers to offer a telehealth-only network and will leave patients without the coverage they need. Also, line 4.8 requires insurers to reimburse a provider for services based through telehealth on the same basis and at the same rate as they would if provided in person. These are the two issues that I'm mentioning that the business community and the health plans have problems with. And in response to that is much discussion about the greater efficiency of telehealth. These efficiencies are mostly for the patient. The cost for providing the care, the practitioner's time, the electronic health records cost, the scheduling and billing staff exist whether the service is in person or through telehealth. And telehealth does not eliminate in-person care, and the cost to maintain a physical clinic, rent, utilities, nursing staff still is there. So again, there is no language requiring telehealth. It is still and always a choice. And Mr. Chair, I do have an amendment.
Senator Rosen, is that the A13 amendment?
Yes, it is, Mr.
And,
Chair.
Senator Utke, would you move the A13 amendment?
Mr. Chair, I move the A13 amendment.
Senator Utke moves the A13 amendment. Members, we will go ahead and vote on the A13 amendment. If you are in favor of the amendment, please say aye and raise your hand.
Aye.
So 210 days total.
Aye.
So essentially,
Those opposed to the amendment, please say nay and raise your hand. The ayes have it. The motion carries. Senator Rosen, to your amendment.
Thank you, Mr. Chair. It basically on line 2.34, before the period, insert subject to the enrollee's selected network of healthcare providers under the enrollee's health plan. And this is comfort language for the plans in this amendment. It clarifies that enrollees who are in a narrow network plan cannot use telehealth as, thank you, Steve. Cannot use telehealth as a way to get coverage outside those networks. Patient must comply with the health plan's network requirements. And this was a piece that was of concern last week in Senator Benson's committee. It was, it's one of the health plan's asks, and we feel this is a good piece to put in this bill. And with that, Mr. Chair, that is basically the bill. I stand for questions. Thank you.
Any questions for Senator Rosen? Any questions for Senator Rosen? If you have a question, please raise your hand. Senator Utke.
Thank you, Mr. Chair. And I really don't have a question. I have a comment. Senator Rosen asked if anybody has experienced this, and I have used telehealth through things that I had going on, and there are some things that work very well, and there's some things that I choose to go back and see the doctor face to face, and that's the nice part of this. It's flexible, and so it's a good deal because I think it's great for the patient. We can have access to health care no matter where we're at, and you know, when we need to actually go visit the provider, we can do so. So thank you.
Senator Franzen.
Thank you, Mr. Chair, and I guess either I'm having technical difficulty, but I can't see Senator Rosen during her testimony, but we assume that was her in the dark screen. But anyway, I wanted to thank her for Mr. Chair and Senator Rosen for bringing this bill up moving forward. I know there's still some kinks or some issues that are still needing to be addressed, like the reimbursement, just like they would be, telehealth would be the same reimbursement as an in-person appointment. And I know that there's still some technicalities with that. So I hope that we can find a way to move this forward and get the support of all stakeholders, and I'm assuming some of them will be testifying on that, but I just wanted to voice my support, but also acknowledgement that there's still some work to be done to make sure that this bill is ready for our floor vote.
Senator Rosen.
Thank you, Mr. Chair, and thank you, Senator Uckey and Senator Franzen, for those comments. Absolutely, there is continued work on this bill. As you all know, a complicated bill like this comes with areas that people feel passionate about, and I can tell you the plans, as I said, they want the separate provider network, and I feel that is really going to be difficult to do that. That's where you're going to have your small communities negotiating with your plans, and the parity issue. There's going to be a disparity issue with your small providers and small community providers, and I just think that's a problem. But I am committed to getting everybody around to the table, especially after this hearing, if we pass it through, because everybody has to give a little bit. And as I said, telehealth has worked extremely well with mental health, with substance use disorder, especially with telephone. And, the question is, does it need to be paid at the same rate? I feel it does, because you're still using the intellectual property, the doctor, the psychologist, you're still doing electronic records, you're still billing and staffing. But there is a lot of discussion around value-based, and I know DHS has problems with the telephone part, because they feel that the telephone will only be used for MA patients, and the private payers will have the option between audio or video. And I guess I just really disagree with that. I don't think that's going to happen. I don't think there's going to be that distinction. But Mr. Chair, I can assure you, in any of these big bills, the conversation continues, and this conversation is continuing. I've had everybody around the table several times, and we will continue. Representative Morrison has the bill in the House, and she's committed to a bipartisan bill also.
Senator Housley.
Thank you, Mr. Chair. And my screen for you, Senator Rosen, is also black in the office, but I can get it on Senator Franzen. You can turn on channel 55 and you'll see Rosen live and in person on your TV in your office. But yeah, on our screen, she's not there. Thank you so much, Senator Rosen, for bringing this bill forward. It is so critical, especially now during COVID, and how many people have used it. One of my neighbors is a telehealth doctor, and I think he's working even more now than he did when he was going into the office every day, and all the people that he's able to reach and help. So thank you so much for this. I just have one question. What's the cost, do you know, to the public programs by lifting the 3 counter limitations?
Senator Rosen.
Mr. Chair, I do not, but perhaps one of the testifiers would have an answer to that.
Sorry, I can wait.
Okay, thank you.
Any other members have any questions before we go to the testifiers? Seeing none, we will go ahead and start with the testifiers and members. We have a number of testifiers that signed up to testify today, and I've asked all the testifiers to limit their comments to 2 minutes and to section 1 of the bill. So when you're as testifiers, when you're called upon, please state your name and who you're with for the record, and then begin your testimony. And we'll start with Mr. Dan Andreessen. Mr. Andreessen, are you with us?
Yes, I am, Mr. Chair. Please
go ahead.
Mr. Chair, members of the committee, my name is Dan Andreessen with the Minnesota Council of Health Plans. Thank you for the opportunity to testify today, and we appreciate being able to chat with Senator Rosen about this bill in past meetings. The delivery of health care has changed since the legislature last debated telehealth policy 6 years ago. Technology has advanced, providers have adopted the technology, and patients have access to care at a time and place that works for them. I want to be clear, the Council fully supports the ongoing use and expansion of telehealth for all Minnesotans. Our nonprofit members have supported access to telehealth since 2015. and the council supports much of the language in Senate File 1160. But as Senator Rosen mentioned, we are respectfully opposed to language that continues payment parity and replaces restrictions on the creation and incentivization of virtual networks. The council is not advocating for any changes during the peacetime emergency. The current temporary laws ensure patients can maintain access to providers, and providers can still see patients to stay financially afloat. But as we emerge from the pandemic, we need to take an honest look at parity and the overall cost of telehealth. Healthcare is expensive, and these increasing costs are paid by Minnesotans through an out-of-pocket cost for services, health insurance premiums, and in taxes used for state public programs. We agree providers should be paid for their expertise. It's also likely the overall cost to provide care through a phone call or video chat is less than when a person is in a clinic, or any savings for the telehealth should be passed on to the consumer. Because of the temporary changes in parity, we have seen copays increase for telehealth visits during the pandemic, especially for phone calls. Here's one example for one of my members. A person on a high deductible health plan may have a copay of around $150 for a face-to-face appointment. During the pandemic, they would pay, or before the pandemic, they would pay a copay of $60 for an appointment over the phone because there was flexibility for payers to negotiate with providers. Now, during the pandemic, copays for phones are at $150, the same for a face-to-face appointment. This would become permanent with the passage of Senate File 1160. It's important to note that moving away from parity or incentivizing virtual networks does not necessarily mean paying providers less for telehealth services. It could be a parity, or payment could be increased when tied to quality and outcomes. These are decisions that should be made between payers and providers for what's best for their patients. The council supports legislation to find long-term solution and address increasing healthcare costs and what's best for patients. Thank you.
Thank you, Mr. Andreessen, and members will ask questions once. Thank you, Mr. Andreessen, and members, we will hold the questions until all the testifiers have testified. So if the testifiers, after you testify, if you would stay with us in case we have questions once the testifiers have all testified. So next we have Mr. Dan Dwight. Dan, welcome to the committee.
Thank you, Mr. Chair, members. For the record, my name is Dan Dwight. I am here today representing the Minnesota Business Partnership. As you probably know, we are a membership organization of business leaders from across the state who employ more than 500,000 Minnesotans. Affordable health insurance and access to quality health care is very important to our members. I'd really like to thank Senator Rosen for working on this issue. We support the goal of this bill and are happy to continue working with stakeholders and the author to get something done this session. As we've witnessed during the pandemic, telehealth is very important for patient access. And it's shown to not only maintain patient access during times like this, but also to improve patient outcomes. As I was saying, patient outcomes are central to healthcare delivery, and we need to have those as our primary focus, I think. Value-based care arrangements have proven to be pretty successful at controlling costs and increasing outcomes for patients. And we think that it would be wise to consider their expanded use in this arrangement if it makes sense. One thing we need to take into consideration as we debate this bill is some protections against frivolous and fraudulent overutilization of telehealth. Mr. Andreessen mentioned this before, but the technology is evolving. What we're able to do now versus 2015 when this was first passed has really improved, the interaction between a patient and a doctor over a technology platform like we're using today. And the technology for remote patient monitoring has also vastly improved. We should use this opportunity to focus on value and patient outcomes using those technologies and make sure that we have platforms that are able to evolve as time goes on. Those are my brief comments. I'm happy to answer any questions, but thank you, Mr. Chair and members, for your consideration today.
Well, thank you, Mr. Dwight. And next we have Thank you, Mr. Dwight. Next we have Mr. Bentley Graves. Bentley.
Thank you, Mr. Chair and members. I appreciate the opportunity to testify today. I too want to thank Senator Rosen for the work she's done on this bill and for the level of engagement that we've had in discussion with her thus far on this bill. It's been very much appreciated, and we think it's already led to a much better bill with changes that were made at the previous hearing And now some additional changes made today to kind of tighten up that language around use of and access to providers using virtual care. When we survey our members, every year about a whole host of issues, including healthcare issues. And this summer and fall, we surveyed them. We found a significant interest on this side of the pandemic in really increasing use of telehealth to increase access and as a hopeful means of curbing costs for themselves and their employees. And some of the changes that I mentioned before, I think help move us in the direction of making sure that this is a bill that does just those things. But as Senator Rosen noted, there are still a couple areas of the bill that we invite more discussion on around the construct of telehealth networks and virtual networks, and also making sure, as was noted earlier, that we are able in this bill to kind of harness the good that can be done through value-based payment arrangements, both to lower costs and to ensure greater and better outcomes for patients. So we know that there is a long way to go on this, but again, we've committed to continuing to work with Senator Rosen, the advocates, and others on both sides of this to find a way forward on this bill, knowing that there's important work here that can and should get done for the people of Minnesota this session, and we look forward to playing a constructive role in that. So thank you all, and happy to answer any questions you may have.
Well, thank you, Mr. Graves. And next we have Ms. Jessica Young. Jessica?
Hello, Mr. Chair and committee members. My name is Jessica Young, and I am a Policy and Advocacy Manager at the Medical Alley Association. We are the cross-sector healthcare association in Minnesota that supports and advances Medical Alley's global leadership in health, innovation, and care. Thank you so much for the opportunity to testify today on Senate File 1160. We want to thank Senator Rosen for her leadership on this issue, and we too look forward to working with the authors and stakeholders as the bill moves along in the process. First, we would like to thank the author for substituting the word telehealth for telemedicine. This is an important update in terminology that more accurately reflects the reality of virtual care delivery. We appreciate the expanded definition of originating site to the location of the patient when they are provided telehealth. We are also thankful for the inclusion of telemonitoring, as clarity on the coverage of telemonitoring is a significant priority for both our members and their patients. Both of these changes will be beneficial to patients as they will allow them to access quality, clinically appropriate care safely from where they are located. We appreciate the modification to the definition of telehealth that the author has included in the bill. We do, however, believe that the definition of telehealth outlined in Senate File 780 may be a better approach. We support the addition of language clarifying that value-based arrangements or payment models are not bound by the payment parity portion of this legislation. It is important to provide clarity to plans, providers, and innovators that these types of forward-looking care models can operate in the way that makes most sense for the patients. We do have concerns with the language in the bill that limits a patient's ability to access health networks that do not include network providers who provide in-person care for the same service. This language could inhibit the development of innovative care models or other care plans that are able to deliver high-quality care for a lower cost in certain situations. Medical Alley Association, on behalf of our over 600 members, looks forward to continuing conversations with the bill author on this legislation, and we again thank Senator Rosen for bringing the bill forward. Thank you.
Well, thank you, Ms. Young. And next we have Jason Flores. Jason?
Thank you, Mr. Chair, members of the committee. My name is Jason Flores. I'm the State Director of Americans for Prosperity, Minnesota. Thank you for the opportunity to be here today to testify in support of this bill. And thank you especially to Senator Rosen for all of her work on the issue. You've heard a lot and you're going to hear more about the benefits, efficiency, effectiveness, the ease of access, the cost savings. I'm not going to restate those facts. Let me put this into a broader context for a minute though. COVID-19 exposed a tragic reality. In many ways, our healthcare system is undermined by bureaucracy and red tape that prevents doctors, nurses, medical professionals from actually helping people. Even as access to quality care has become more important than ever, many Minnesotans have been limited in their ability to get the care they need, and not just by COVID. In April of last year, we commended actions at both the federal and state levels, including the governor's executive orders on the subject, that removed many of the bureaucratic barriers that stood in the way of accessing new innovations in care. Across the nation, telemedicine restrictions were waived to allow safer doctor visits from home. Licensing laws were suspended, giving medical professionals the ability to work where they were needed the most, even across state lines, and restrictions on hospital beds and equipment were lifted. The result can't be understated. Lives were saved as a result of these important reforms. Now, these changes were viewed by some as merely temporary, necessary only within the parameters of the much broader healthcare response to the pandemic. But if temporarily removing these regulatory barriers to care helped improve the health of patients, helped deal with hospital capacity issues, and lowered costs, then why wouldn't we want those barriers to stay down permanently? Now, specific to this bill, it is our hope that Minnesotans learn from these pandemic-related experiences and permanently remove unnecessary regulations on the delivery of telehealth. And that's why we support this bill. We also do support ongoing conversations about these issues of payment parity as well, again, because of the bigger issue that is behind it all. Anytime that the state interferes with flexibility in business practices or mandates certain pricing structures or picks predetermined winners and losers, it is going to distort the market. And neither patients nor providers will see the full extent of the potential benefits in terms of quality of care or cost savings. Look forward to continue to support this bill as it moves its way along. And thank you again for Senator Rosen and this committee for your consideration and your support.
Thank you, Mr. Flores. Next, we have Ms. Sarah Schmidt. Sarah?
Hi, thank you, Chairman Dames and members of the Senate Commerce Committee for having me here to tell my telehealth story. And thank you to Senator Rosen. My name is Sarah Schmidt, and I'm a children's mental health therapist with Wilder Foundation in St. Paul. I'm here to speak in favor of Senate File 1160 and highlight the importance of the new definition of telehealth. A current client of mine is an 18-year-old Karen refugee living in St. Paul. This young man has a diagnosis of major depressive disorder. We began weekly therapy sessions back in July of 2020. One Saturday evening in late October, I received a text from this client telling me that he and his sister were being held at gunpoint against his will, and he begged me to respond and contact the St. Paul Police Department. I spent 20 minutes on the phone with police dispatch while my client and I continued to text about his whereabouts, the location of the gun, and who was all involved in this situation. I'm happy to report that this situation was peacefully resolved for my client and his sister, and that an arrest was made. During another session in January of 2020, I conducted a regular symptom check-in with my client. This particular week, my client rated his depressive symptoms as very high, and he confided in me that he had serious suicidal ideation. My client told me he had not been attending school and that he was distancing himself from his younger cousins because he didn't want them to be sad should he decide to take his own life. After consultation, I was able to convince my client to take himself to United ER for emergency assessment. He was subsequently hospitalized and has since been released. I'm happy to report that my client's suicidal ideation is lessened and his depressive symptoms are manageable. Now here comes the surprising part of the story. I have never once seen my client, not in person, not over a video screen. We meet each and every week over the good old-fashioned telephone. He could be walking down the aisle at Target next to me and I wouldn't know it was him. Does this lessen my therapeutic relationship with my client? I would say a resounding no. Audio only may not be the right mode of service for everyone, but having audio only as an option gives me, as a provider, another tool to best serve my clients. Thank you again for listening to my story and the story of my resilient client. I would urge this committee to pass SF 1160 and keep the audio only option available at the same reimbursement rate for telehealth providers. Thank you very much.
Thank you, Ms. Schmidt. Next, we have Dr. Sarah Manney. Dr. Manney.
Thank you, Chair Dons. My name is Dr. Sarah Manney. I serve as Essentia Health's Chief Medical Information Officer, and I'm also a pediatrician in Duluth. On behalf of the Minnesota Hospital Association and Essentia Health, I respectfully request your support of Senate File 1160. Essentia Health is an integrated health system serving patients in Minnesota, Wisconsin, and North Dakota. Since March 2020, Essentia Health has conducted approximately 389,000 virtual visits directly to patients, with almost 40% of these visits being offered over the telephone. During this time, these virtual visits have allowed Essentia Health to conduct over 80% of its mental health encounters, avoid countless ER visits, and save patient lives. While the number of virtual visits has leveled off since the early months of the pandemic, virtual visits still account for roughly 20% of Essentia's encounters and will remain an important tool for ensuring access to care throughout the rural and underserved communities we are privileged to serve. As a pediatrician, I have experienced the overwhelming benefits of virtual visits firsthand. And my first virtual visit that I ever did back in March was quite surprising. It was a follow-up visit with a mom and her infant. The child had been recently hospitalized. And as I was talking with the mom and she was able to show me her daughter as we were talking, it was very clear that the child was deteriorating and was quickly deteriorating in the last couple hours. I was able to create a plan that got her safely to a higher level of care, and I truly believe that the technology saved her life. Because if she had to drive into my office and I would have to call for transport to the emergency room, I think the outcome could have been vastly different, and she's alive and thriving today. I've also been able to provide mental health services to a teenager living in rural Minnesota. The visit was wonderful because I was able to see both parents with the child, and that hadn't happened in many years. It takes a whole day of work for them to take off to drive all the way to my office to see me in Duluth and then to drive all the way back home. It was a wonderful visit too because the child's church was able to provide the broadband internet that we needed for the visit and also a private room to conduct the visit. And that child is also doing really well, and it was wonderful to be able to have a family visit to plan her care going forward. So these are just a few examples of how I can leverage the benefits of virtual visits for my patients. For these reasons, we ask that the committee to support Senate File 1160. Thank you for your time and consideration.
Thank you, Dr. Manney. And next we have Kyle Zebley. Mr. Zebley.
Thank you so much, Chairman, and thank you to the committee for allowing me to testify. I'm Kyle Zebley. I'm the Director of Public Policy at the American Telemedicine Association. Senate File 1160 serves as an important addition to Minnesota's state telehealth policy. The ATA is strongly supportive that the bill requires insurance plans provide equal coverage for services provided via the appropriate telehealth technologies. Mandating that health insurance plans cover telehealth services to the same extent as in-person care would make it easier for Minnesota residents to access quality health care at any place at any time without having to worry about the potential financial burdens associated with receiving that care. We also support the bill that the bill will enable healthcare professionals from a range of fields to deliver care through telehealth, including mental health professionals. While we support the bill, we do recommend a few amendments to better advance telehealth in the state. First, the proposed definition of telehealth could create confusion in that it defines telehealth as requiring a quote unquote real-time communication. The definition that telehealth includes store and forward transfers, even though store and forward transfers are not real-time communications. We recommend the legislature revise the definition to make it similar to the technology neutral language found in SF 780, which would ensure that licensed providers determine which technologies are appropriate to treat the conditions presented by the patient. Second, we ask that the committee reconsider the limits put on telemonitoring coverage for Medicaid beneficiaries. The ATA believes telemonitoring should be an available option for all patients so long as the appropriate standard of care is being met and there is medical necessity for the service. Thanks so much for your time today and for your interest and support for telehealth. And please do not hesitate to let the ATA know how we can be helpful to your efforts to advance rational and effective telehealth policy in Minnesota. Thanks so much.
Well, thank you, Mr. Zebley. And next we have Mr. Dave Reiner. Mr. Dave Renner.
Mr. Chair and members, thank you for the opportunity. My name is Dave Renner. Excuse me. I'm here representing both the Minnesota Medical Association and the Minnesota Academy of Family Physicians. The goal of physicians is to make sure that patients have access to health care no matter their circumstances. One of the maybe good things that came out of COVID has shown us the value of the expanded use of telehealth, which has been critical for patients to receive care that they desperately need. Without the bill that you're debating today, many of those expanded covers, however, expire in June. To be clear, telehealth is not a substitute for in-person care. It's simply another way of delivering care. Not every type of care can be done with telehealth, but much of it can. As many of you know, in many parts of Minnesota, we continue to have access problems with strong broadband. In addition, many elderly patients especially are not comfortable with using computers or smartphones. And of course, there are many patients who cannot afford tablets, computers, or other technologies for video visits. Telephone-only visits are necessary to ensure that these patients continue to receive health care. Some have argued that the quality of care delivered during telehealth visit cannot possibly be the same as the quality of an in-person visit, but our research tells a different story. This past July, the Minnesota Medical Association conducted a survey where 84% of physicians reported that telehealth services were meeting the need of their patients. And more importantly, 83% of patients said they liked and were satisfied with their telehealth visit. Telehealth does not reduce the requirement to provide quality care. It does not change the physician's duty to the patient, nor the requirement to meet the standard of care, whether it's via telephone or whether it's via video. The current law requires insurance to pay the same reimbursement for services regardless of whether they're inpatient via telehealth. And Senate File 1160 maintains that requirement. The savings and the efficiency that many people hear related to telehealth fall mostly on the patient, not the provider. The costs of providing care via telehealth are pretty much the same as in-person care. The professional fee is the same. Staffing and scheduling costs remain. There's requirements for the electronic medical records. We would argue that this bill should not allow insurers to artificially reduce payments that they currently make. In addition, as has been said a number of times, at best 20 to 30% of care is telehealth, so there is still a need to maintain a physical clinic as well. You need to know that the positive impacts that telehealth services have had on your patients in your districts, particularly patients in rural and underserved area. Without the ability to use telehealth from their homes or to have telephone-only visits, many of these patients would be forced to forego treatment. We ask you to support Senate File 1160, and I'm also happy to take any questions.
Well, thank you, Mr. Renner. And next we have Mr. John Magnuson. John.
Thank you, Chair Dames and committee members, for the privilege of testifying before you today. My name is John Magnuson. I'm the Executive Director of MARCH, the Minnesota Association of Resources for Recovery and Chemical Health. MARCH is a professional association of addiction treatment professionals and organizations that are striving to raise awareness about addiction and the power of recovery. We represent more than 75 agencies and a workforce of more than 5,000 individuals with members in every region of Minnesota. MARCH has already submitted written testimony, which I hope you'll review, but we need to highlight the importance of rate parity for providers. Our providers aren't saving money by providing services via telehealth. Whether services are provided in person or via telehealth, we're spending the same amount of time with clients. Our clients realize conveniences associated with transportation, childcare, and travel time, including time away from work. These conveniences for our clients are also increase their engagement with their treatment and therefore our ability to better serve them. We as providers also have to absorb the additional costs of ongoing hardware, software, and technology upgrades. Remember, it was only possible for our field to ramp up to where we are today due to the federal and state funds provided as a part of COVID relief. We need rate parity to continue telehealth. Therefore, MARCH supports SF 1160 and thanks Senator Rosen for her work on this important legislation and ask the committee to ensure that rate parity is maintained. Thank you for your time.
Well, thank you, Mr. Magnuson. And members, next we'll have questions for the testifiers. So if you have a question, please raise your hand and then state your question and then state who you're directing the question to. So members, are there any questions of the testifiers? Members, any questions to the testifiers? Seeing none, Senator Rosen, any final comments on the bill?
Yes, thank you very much, Mr. Chair and members. Again, you heard really great testimony, and the bill is working its way through. It's getting better by each stop. I believe here we go to Senator Abler's committee. Telehealth, again, complements the healthcare delivery. It's not here to replace it. But I'm very concerned about
the parity issue, going back on that issue, the parity payment issue, which the plans want to do. I think there is a sweet spot we can get to on that, but to reverse what has been in place since 2015 and basically penalize telehealth and a parity just because of increased use doesn't seem to be right for me. But I do believe there is a sweet spot we can get to on that. No one has come up with any cost-saving figures on the no-shows that are obviously down, significantly down because of telehealth. No one's given me a cost savings on the ability for our seniors, our underserved, our rural, our disadvantaged, how they can access healthcare through audio only or telephone. That is, they are getting their healthcare, and yes, it is through audio only, but it is a professional on the other end. So I do believe the bill is getting set up really well. There are some issues that we are still dealing with, but it addresses many of them. There was an issue that Mr. Zebley from the American Telemedicine Association on telemonitoring, that is being worked on. I didn't think that was appropriate to amend in your bill, probably more appropriate in Senator Abler's bill to expand some of the conditions that telemonitoring could be used for. But because of COVID, we've been introduced more to telemedicine, and I think it has a place in our healthcare framework and delivery system, and we just need to get it right. So, Mr. Chair and members, I pledge to you, along with any big bill, we'll continue to work on this, and we'll get it right with all the stakeholders.
Well, thank you, Senator Rosen.
Thank you, Mr. Chair. Yes, I move that Senate File 1160 be recommended to pass as amended and re-referred to the Human Services Reform Committee.
Well, thank you, Senator Utke. Senator Utke renews his motion that Senate File 1160 be recommended to pass as amended and re-referred to the Human Services Reform Committee. Members, we're going to go ahead and vote. When you vote, please not only voice vote, but raise your thumb on your screen so that we know that you're voting. All those in favor signify by saying aye.
Aye.
Opposed, nay. The ayes have it. The motion carries. And thank you, Senator Rosen. And you'll be going next to the Human Services Reform Committee.
Thank you very much, Mr. Chair and members. Appreciate it.
And members, next we have Senate File 1020, which I am the author. And so I'm going to turn it over to Senator Utke. Senator Utke, would you take the gavel?
Thank you, Senator Dames. Members, Senate File 1020 is now before us, and Senator Dames, I believe you have an A1 author's amendment that you want to bring before us right away to get your bill in order.
Yes, Senator Utke, I would move Senate File number 1020, and then the A1 delete all author's amendment.
Thank you, Senator Dames. Members, the A1 is an author's amendment, so we will move that to bring the author's bill into the form that he desires. So get with your mics, with your audio on. All those in favor of the A1 amendment, please signify by saying aye. Aye.
Aye.
Opposed? Motion passes. Senator Dames, your bill as amended.
Well, thank you, Senator Utke, and I'm presenting Senate File 1020 today to clarify what is considered a prohibited practice for entities offering continuing education courses for realtors, commercial real estate, and insurance agents. Last fall, as commerce in the industry were discussing how to move CE online due to COVID, Commerce had issued a bulletin that very strictly interpreted current law and caused confusion among the CE provider community. The A1 amendment provides 4 very specific exceptions to prohibit activities listed in the bulletin that would allow CE providers to offer courses to enrollees and clear up the confusion around the bulletin. The A1 amendment would allow CE providers to do the following: display a logo or company branding, put a trade show booth outside the classroom that is separate from the CE registration table, display a logo to thank sponsors or underwriters during a break, display a logo or advertising on course program. Course program is defined as literature detailing the schedule of events, presenters, course detail, and background information. This bill as amended has been negotiated with the stakeholders, and I understand everyone is in agreement on the issues. With that, Mr. Chair, I believe that we have a few people that like to testify.
Thank you, Senator Dames. Yes, members, we have 5 testifiers that are before us today, and I will call on them. And testifiers, please, when I call on you, state your name for the record and then begin your testimony. And first up, I have Kyle Byrne. If you're with us here, you're up.
Thank you, Mr. Chair. My name is Kyle Byrne. I am the Director of Public Policy with the Minnesota Multi-Housing Association. I just wanted to thank the rest of the stakeholders and the Department of Commerce for working with us on this. We've reached an agreement that we can all feel happy with. So we support the proposal and ask for your support.
Thank you, Mr. Byrne. Next up, we've got John Reich, and then Ms. Rowan will be following John.
Mr. Chair and members, thank you for the time today. Sorry for the delay. John Reich, Winthrop & Weinstein Law Firm in Minneapolis, and I'm here representing Minnesota Real Estate Journal. And we wanted to just thank the author, Senator Dames, for carrying this important bill for us. As he mentioned in his comments, it does clarify some of the issues that were raised last fall in our discussions with the Commerce Department as it relates to the provision of CE courses. I want to thank also Mr. Brickwoody at the department for engaging in a discussion over the last few months to figure out a path forward, and I think we do at this point. So thank you, and I'm happy to stand for any questions.
Thank you, Mr. Reich. We will take questions and comments after we've had all of our testifiers. So next up, Ms. Rowan.
Good afternoon, Mr. Chair, committee members. My name is Robin Rowan, and I'm here on behalf of the Minnesota Independent Insurance Agents and Brokers. I'm testifying in support of Senate File 1020. We represent over 6,500 insurance agents in Minnesota and have been providing CE classes for over 50 years. I want to thank Chair Dames for bringing this bill forward and the Department of Commerce and Peter Brickwoody for working with us on what we feel are very common sense clarifications and updates to current law. We consistently hold over 200 CE classes a year, and over 3,000 agents take our classes. We are a nonprofit, and we produce quality, and producing quality CE classes is expensive. We spend over $600,000 a year on our CE programming, yet we think it's critical to keep CE affordable for our agents who are required by the state to take it. Having corporate partners helps us do this, and the clarifications to the bill preserve our ability to provide value to these partners without compromising the quality of the education that we're providing our attendees. So thank you, and I'm happy to answer any questions.
Thank you, Ms. Rowan. Next up, Greg Sather. Mr. Sather?
Sorry, I had to unmute my mic there. Good afternoon, Chairman Dames, members of the committee, Chairman Upke. I am Greg Sather, Executive Vice President of the Professional Insurance Agents of Minnesota, where I have served as the CE coordinator for the past 20 years and also have been an instructor. While we were not party to the discussion that led to this bill and its amendment, we are affected by it. One of the things we've noticed is it seems that everyone seems to interpret the CE statutes differently. We have had conventions in several different venues over the years. Most of them have incorporated a trade show and recognition of sponsors between CE sessions. And we have had vendors and sponsors in the same room as the education. We're a smaller organization than the one that Robin testified on behalf of. And sometimes we had a larger room with the vendors and everything set up in the back of the room. There was no recommendation or promoting of the services of any particular business, but we were all there together, just like we are in the insurance business. On numerous occasions, we have had Commerce Commissioners, Assistant Commissioners, or Department of Commerce Enforcement, or other staff present a CE course for us. Not once has any of them said we were doing something that we should not be doing, but instead comment on the quality of our event. What appears in Subdivision 3, Part 2, to be an attempt to expand the existing statute, in our view, is more limiting in our case than what our interpretation of this law has been. It concerns us. It appears that all of the points listed in the exceptions are meant to acknowledge the fact that you're never going to achieve a sterile CE environment. Face it, agents know that the organization they know what organization is providing their CE. They know that the name of the glass company that is providing their free CE. In the case of association events and conventions, I believe agents deserve to know who has helped defray the cost of bringing them quality CE. As Robin mentioned, it is expensive. And these are sophisticated professionals. They're not going to be swayed by the simple appearance of a logo. There are already prohibitions about recommending or promoting particular services under a particular business. I would actually recommend simplifying the statute by removing point 3 under prohibitions and not worry about materials, clothing, or logos at all. While we're not speaking in opposition of this bill, we do welcome further discussion on it and anything we can do to help simplify the CE statutes. Thank you for your time today.
Thank you, Mr. Sather. And next up, we've got from the Department of Commerce, Mr. Brickwoody.
Thank you, Mr. Chair. For the record, Peter Brickwoody, Assistant Commissioner at the Commerce Department, and I will join the chorus of thanks. First, Mr. Chair Dames, to you as the author of this bill for giving us the space to continue to work with groups who have testified earlier today, amongst others. I'd like to echo their thanks and appreciation for the process. I would add to it that I think had the department and the Minnesota Commercial Realtors Association with Matt Anfang and the members of that organization not been engaged in a dialogue last summer that led to the issuance of that bulletin and the subsequent conversations that we've had, that we would not be before you here today with a proposal that we have been able to work out, that we think will actually help provide clarity to the continuing education students, coordinators, instructors, all of the players, and preserve the department's position to be both the issuer and approver of that CE and the enforcement agent on complaints. I think members, the thing that I think we're able to achieve in this proposal is a balance between reading the existing law in Section 1 and the new Subdivision 3 in the author's amendment in concert with one another, and really articulate clearly that there's an agreement between these parties that there's a differentiation between the display of a logo or a visual identity and the use of that logo or visual identity to run a commercial to a captive audience of CE students. And so it took us some time and some effort to get to language that we could agree on. And I want to express the department's appreciation. I think this is a reflection of how we can work together and bring to the legislature a good public policy crafted in concert with one another, so that we can be able to serve the needs of our regulated entities. With that, Mr. Chair, I will stand for questions.
Thank you, Mr. Brickwoody. Now we're to questions. Members, questions, comments for any of our testifiers or for the author? I'll just ask one question here for Mr. Brickwoody. Were you receiving, let's say, questions or people that were complaining that there was a problem at the department?
Mr. Chairman, the department receives complaints, I think, on a regular basis and has. I think the impetus for the bill that you have before us was, I think Mr. Brandt pointed this out at the outset, that as we were transitioning last year into an environment where real estate students in particular and commercial realtors in specific regard to the conversations we were having with the Commercial Realtors Association, were in need of making sure that they could access quality continuing education in an online environment where, particularly in commercial real estate, our sense was that many of those students and many of the providers had built a business model that was more brick and mortar and relied on in-person events, which were not going to be possible during last year's real estate renewal season and had been not available in large part throughout the course of the pandemic. So it was in that attempt to translate an in-person business model into the online environment where we first discovered that there was some difference of understanding, I think, between the department and some CE providers, not all, but some CE providers, about what the current law, which has been in place since 2009, does and does not permit. And so I think it was through those conversations that we issued the bulletin that was referenced earlier, along with the frequently asked questions document, which was an attempt to try to provide a little bit more plain language explanation of the bulletin. And then the subsequent conversations about the legislation came from there. And I think, Mr. Chair, the issue in our mind is not necessarily about how many complaints we may get, but rather trying to make sure that on the front end, the law is clear to all parties so that we try to avoid having complaints in the first place.
Thank you, Mr. Brickwoody. Members, one more chance here. Any questions, comments for our testifiers or author? Otherwise, seeing none, we'll go back. Senator Dames, do you have final comments, and then you can renew your motion?
I'll just go ahead. Mr. Chair, thank you. I renew my motion that Senate File 1020 be recommended to pass as amended and placed on general orders.
Okay, thank you, Senator Dames. As he renewed his motion that Senate File 1020 be recommended to pass as amended and placed on general orders. Everyone understand the motion, and please unmute. We will vote. All those in favor of the motions, please signify by saying aye and give us a thumbs up. Aye.
Aye.
Opposed, same sign. Motion passes. Thank you. Members, that concludes the business in front of us today. With that, we will stand adjourned. Thank you.